So, good afternoon. I know that you had a very short, quick lunch, so thank you very much to be here to hear what I will expose to you dealing with the electrohypersensitivity and multiple chemical sensitivity. You may ask the question why a medical professor, a professor in medical oncology will speak about these two disorders. The reason is very simple. When I was in Paris at the Hôpital Georges Pompidou, the European Hospital Georges Pompidou, patients came to visit me and asked me, do I have a brain tumor? And I answered to these patients, no, but you may have some clinical manifestation of electrohypersensitivity. I think that, you know, we are dealing with, I would like first to dedicate my presentations first to thank very much the organizer of this symposium and to dedicate this presentation also to Martin Blanc, with whom I had some contacts before he died, and to Franz Abdelkoffer, that I invited several times in Paris for giving conference, to give conference. And, you know, I know now that he is in Greece, where he is retired, and he said to me recently, I do want now to be relatively quiet. So this is, you know, the objective of my presentation is to try to identify and characterize electrohypersensitivity and multiple chemical sensitivity. So this slide is only to recall you that it's, you know, a long fight that scientists had first in 1996 in Berlin, where there were a WHO-sponsored workshop, and at that time, MCS was classified as an idiopathic environmental intolerance. In 1997, in Stockholm, at that time, it was the first, you know, report that tried to associate electromagnetic field exposure to symptoms, to clinical symptoms. And this was prepared by a group of scientists for the European Commission. In 1998, in Austria, there was the COST 244, this international workshop on EHS. In 1999, in Atlanta, a very important report was the MCS 1999 consensus. As you may know, in 2002, the IRC classified extremely low frequency as possibly carcinogenic, group 2B. In 2004, in Prague, a very important meeting sponsored by WHO was to classify, to identify the framework of, the framework of idiopathic environmental intolerance attributed to EMF. You see, this was not really a good definition because there are two terms in this title, which are contradictory. In one way, it is said that it is an idiopathic environmental disease or disorder, and in the other way, so without any clearly cause, but in the other way, it is attributed to electromagnetic field. In 2005, WHO, just 1 year after the Prague Congress, spoke about the electromagnetic electrohypersensitivity and say what we will see in a few minutes, that we can recognize the disorder, but not linking causally this disorder to electromagnetic field exposure. And in 2013, there was the 2B classification of radio frequency by the ERRC. So in 2015, we organized in Brussels a workshop which was maybe a good step toward the WHO, as I precise to you in a few minutes. I would like to remind you also what is the meaning of electrohypersensitivity for WHO. EHS is characterized by a variety of non-specific symptoms that differ from individual to individual. I would try to demonstrate that this is not the case. The symptoms are certainly real and can vary widely in their severity. This is true. Whatever its cause, EHS can be a disabling problem. They don't say disabling disorder, but only a problem for the affected individual. So the individuals are affected, but they are not, affected by an affection, a disabling affection. EHS has no clear diagnosis criteria. I will demonstrate the contrary. And there is no scientific basis to link EHS symptoms to exposure. This has to be discussed. Further, EHS is not a medical diagnosis. I would say the contrary, nor it is clear that it represents a single medical problem. That is true. So, this definition seems to us at the moment not enough clear, to be recognized scientifically as a good definition. So I will first present, some data we have the data we can report today. As you can see, this is based on 756 patients. Now we can do a similar figure based on more than 2,000 patients. So 29 patients were discarded because not evaluable. Evaluable patients were 72.7, EHS with 77% of the cases, MCS only in this figure 52 cases, and EHS plus MCS was 22, roughly a quarter of the general population. So it is, to my knowledge, the first time that MCS was described to be associated with EHS. So the sex ratio, there is, 3 out of 4 female and only 1 out of 4 male. So there is some susceptibility to female. The age in this series, the age was, the mean and median was 45 years, but we eliminate from this series the age the younger age, including children and babies, for which we had also some suggestion that they could be associated with some electro-hypersensitivity. In my experience, I see babies of 3 months who cry, when they were exposed closely to some Wi-Fi source. So, and the origin of patient now, I have 20% of the patients which came from different countries, Europe, USA, Canada, and so on, and Russia, to have a diagnosis and a treatment. So this is to confirm you that there is no fundamental difference as far as the demography that are concerned in EHS and or MCS self-reporting patients. You have sex ratio is similar with a little more female in the case of the association of EHS and MCS, but roughly we have no difference between the 3 groups. As I said to you, a very important consensus meeting was organized, in 1999, and which defined, what is multiple chemical sensitivity. And first, they define it as a chronic condition with symptoms that recur reproductively in response to low levels of exposure when incidents improve or resolve where incidents are removed. Later on, it was added the 6th criterion, symptoms occur in multiple organ systems. And these definitions, which are purely clinical, no biology, is the one I use to try to include patients as having, some electro-hypersensitivity. This is the clinical picture in comparison to normal controls that we obtain, confirming in some way the other publications. What I would like to stress is that I examine personally all the patients, physically and neurologically, so it's not an interview, I did not use an interview outside of the patients. It's a physical examination. So what we can see, first, headache is very constant. It's very, very important, 90% of the cases, 80% of the cases. Dysesthesia, 92%. Myalgia, very, very often too, and arthalgia also, but less. It's not significant in comparison to controls. Otalgia was very frequent, and we will see in a few minutes that otalgia is less frequent in the case of multiple chemical sensitivity. Tinnitus, 60% of the cases, hyperacusis, 40%, dizziness, and balance disorder. These are very important because we can, these are not only subjective symptoms, they are physical symptoms. And, I could detect a Romberg sign in more than 5% of the cases. That means it is objective clinical symptoms. We have not to say only subjective symptoms. Concentration attention deficiency, 76%. Loss of immediate memory, 70%. So confusion, that was a highly significant too. And you have also symptomatic triad, fatigue, insomnia, depression tendency in many cases, and suicidal ideation. That is very important. And I remind that Abdel Koffer, described the suicide of a pastor in Germany. And I had also in my series some suicide due to, caused by, we don't know, but suicide. I would like to stress that we have to describe the disease, whatever the cause. We are not to mix, the discussion about the causal origin of electrohypersensitivity and what we observe clinically and biology. These are two different topics. Transitory cardiovascular abnormalities, 50%, ocular deficiency, almost the same, anxiety, panic, emotivity, irritability, and often, these symptoms push, the medical doctors who are not familiar with this disease to say it's a psychiatric disease. As I will show you, it's not a psychiatric disease. It is, a disease as other diseases, as I would like to show you to you. Skin lesions, very important. And in about 20% people have skin lesions. This is still, an objective symptoms, clinical symptoms, so not subjective. Global body dysthymia in some patients too. So now I would like to make the comparison with the symptoms that we can observe in the case of multiple chemical sensitivity. And as you can see in this, this is, yes, as you can see, we have similar symptoms than in EHS. Headache, very frequent, dysesthesia, myalgia, arthralgia, same is not, in comparison to normal control, is not significant. Otalgia, less significant, less frequent than for EHS. Tinnitus, hypergosis, dizziness, balance disorder, concentration, attention deficiency, loss of immediate memory, similar. And fatigue, similar. Insomnia, similar. Depression tendency, suicidal ideation. So there is no difference symptomatically. A similar picture, clinical picture, can be obtained when we are patients with MCS associated with EHS, except that we have, for example, a more frequent, more frequently skin lesions, and more frequently suicide ideation. That's very important because it seems that when EHS is associated with MCS, we are dealing with more suicidal ideation. So I would like also to make a comparison between EHS alone versus EHS plus MCS in these patients. And as you can see, headache is more frequent in the case of the association of both disorders. Dysesthesia, same. It's more frequent in the case of EHS and MCS. Myalgia is also more frequent, and arthralgia more frequent too. So also we can consider that balance disorder is concentration attention deficiency is more frequent, and loss of immediate memory also more frequent, and confusion is also more frequent, and fatigue. and insomnia and depressive tendency is more frequent with suicidal ideation, which can reach the figure of 40% of the patients. This has to be, we should take into account this figure. And also, skin lesion was more frequent. About 1 out of 2 patients present skin lesions, objective, so manifestation. And this is the main figure we could observe. So, an important parameter that I would like to expose to you is that we demonstrated, absolutely demonstrated, that there could be a possible association in the same patient of both disorders. To my knowledge, this is the first time that we made this observation. Yeah? Okay. So it's the first time that we describe this possibility of this association in the same patient. Similar symptomatic pictures, similar biological abnormalities as we will see in a few minutes, presume opening of the blood-brain barrier in both cases, similar abnormalities detected by using different imaging techniques, I will show you, similar therapeutic results, I will not show you, but based on the biological marker we could detect, we organize treatment adapted to the biological situation of the patient. No. So, a very important point is that we can now make an objective diagnosis of electromagnetic, of electro-hypersensitivity and MCS. They have, as I will show you, similar biological abnormalities. So we disagree with the 2005 statement of WHO. No. So first number of biological markers deals with low-grade inflammation. And, for example, and there is no statistical significant difference between the 3 groups we individualize, EHS, MCS, and EHS plus MCS. As far as CRP is concerned, you know that 15% of the cases in the group of EHS have an increase in CRP. CRP is not, a marker necessary of low-grade inflammation. Usually it is a marker of high-grade inflammation. But in 15% of the cases in EHS, we have this increase. But 12% in the case of MCS and 14% in the case of EHS plus MCS, no statistically significant difference. Histamine is a very important marker. It is, in the case of EHS, it is increased in 37%, 33% in the case of MCS, and when we have both disorders, 41% of the case. So, but they are not statistically significant. Donc, same, biological histamine increase in the 3 groups of patients. I have to say that we confirm this biological picture in a new independent prospective study we have done that we are publishing now, taking into account 1 at least one biological marker in the inclusion criteria. So to be sure that we are dealing with objective diagnosis of electrohypersensitivity. AGE is increased, in about 20% of the cases in all the groups. Chaperone proteins, HSP70 and HSP27, were increased roughly in 20 to 25% of the cases. This is very important also because, as you know, chaperone proteins are associated with inflammation, low-grade inflammation. So now we are dealing with the demonstration that these patients are associated with some low-grade inflammation. So one of the physical approach we have is to make histamine as a very important marker, which should be, considered as far as the physiopathological interpretation of the disease is concerned. And, we know that histamine is involved in the blood-brain barrier opening. It is not my work, but it is in the scientific literature published. And so we think that we are now settling, some good approach to try to explain the mechanism of the disease. So MCS and or EHS. Two markers we use are very important too. Protein S100B, which is also a marker of low-grade inflammation, but in addition to that, it's a marker of blood-brain barrier opening, as it is the case of nitrotyrosine, which is a marker of nitrosative stress, which, we found, increased in about 15 to 30% of the cases. That means that in these cases, since these two markers are are marker of the blood-brain barrier opening, so in these patients, this strongly suggests that there is some blood-brain barrier opening in 15 to 20% of the cases. Vitamin D is, usually very low, and zinc also is very low. So we have to correct, as far as the treatment is concerned, we have to correct these two abnormalities. A very good marker also is the detection in the 24-hour urine sample, the ratio between 6-hydroxymelatonin creatinine, because in 90% we detect a decrease in the patients with electrohypersensitivity or MCS. So, but in about 10% of the cases, we found some increase of this ratio. So we have no good explanation of that. We eliminate some, some melatonin as a medication, and also some, benzodiazepine, who make another drug that the patient could take to explain this increase in, in melatonin in the urine, which could be associated with an increase in melatonin production in these patients. We have to study that more. So a very important observation now is that we were able to detect some oxidative nitrosative stress in EHS self-reporting patients in the framework of a prospective biochemical analysis. And as you can see, as turbarbituric acid active substance is concerned, you have, some cases out of the normal values in the upper values, and same for malondialdehyde. For nitrotyrosine, same, but in some cases we had some decrease in NTT. So we discussed that in a paper, and we have some physiological explanation of that. For superoxide dismutase, you know that there are some points in the outside of the normal figure, and for glutathione peroxidase, a similar approach, and for glutathione, and especially reduced glutathione, oxidized glutathione, we have also some points, in the out of the normal values. And now I would like to show you the figure we have at the moment. 80% of electro-hypersensitivity bearing patients are associated with some, at least with one oxidative nitrosative stress biomarkers. This is a very important figure because it is found in other diseases, and it is that strongly suggests that in fact EHS patients are associated with true organic disease, and not, as it is said, currently, that it is some nocebo-associated disorder, or even psychiatric disorder. So this figure is, in my suggestion, very important. So now it's not all. We have also imaging techniques which can help us to make the diagnosis of EHS. We use an ultrasonic cerebral tomosphygmography, which is a very sophisticated machine, which is represented by a combination of computer with a cerebral tomosphygmograph, source emitting pulse ultrasounds, and this machine explores the middle cerebral artery-dependent tissue areas in the temporal lobe. What is very important is that, it explores locally what is going on in the temporal lobes. This is a picture we obtain normally in the here. And this is what we obtain in the case of electro-hypersensitivity patients, bearing patients. Same figure for MCS bearing patients. So as you can see, there is a decrease in the pulsations, cerebral pulsation, in the right temporal lobe as well as in the left temporal lobe. In this area specifically, which is a capsulothalamic area, which corresponds to the limbic system and the thalamus. So we believe from this study and from other studies that EHS and MCS are related to some abnormalities in the limbic system and in the thalamus. And if we consider this approach, that means that we have now an explanation of the clinical symptoms we can observe, because as you know, the limbic system, and as it was said this morning, the limbic system is related to the immediate as well as long-term memory, and the thalamus is related to the superficial and deep sensibility. So we have now some explanation, if we agree on that, that electro-hypersensitivity is, and as well as multiple chemical sensitivity, are in fact true organic disorders. Now. We use also some transcranial Doppler to evaluate the blood flow in the middle cerebral artery in the two hemispheres. And that is now, we are publishing this result now. And as you can see here, this is a common investigation that medical doctors can do currently. We have some figure, in which the resistance index can be normal, but we have, in many cases, some decrease in the pulsatility index and a decrease in the mean flow velocity, which means that, in fact, outside of the temporal lobes, there are also other, abnormalities in the brain. So we have, this figure is not very contributive, but I would like to say. We have to distinguish intolerance from hypersensitivity from susceptibility. And unfortunately, in the 2005 report from WHO, there was some confusion in this term. Intolerance can be defined as an occurrence of clinical and biological symptoms under the influence of EHS and or chemical exposure. Tolerance threshold not necessarily decrease. This is very important. We cannot tolerate electromagnetic field, but we may not be hypersensitive to electromagnetic field. So the biological response leading possibly to pathological disorder. This is a definition that I adopt personally to distinguish intolerance from hypersensitivity. Hypersensitivity is a decrease in the tolerance threshold and extension of intolerance to the whole M frequency spectrum and or to multiple environmental chemicals. I think that this is a group of disease, a group of disorders which are defined by the decrease in the threshold of tolerance. Susceptibility has been issued from many studies dealing with cancer. It is defined by innate, genetic, or acquired epigenetic, inherited endogenous factor that contribute to cause and or to amplify intolerance to EHS and or chemicals, and they account for hypersensitivity occurrence. So I think that we should distinguish these three different biological phenomena because for clarification of what is going on. Okay. So there are other, demonstrations that electrohypersensitivity can be, organic disorder. I have to go first. Okay, this is the proposed model we have published, environmental stressor, whatever it is, chemicals or electromagnetic field. In the brain, you have resident microglia cells and mastocytes, including mastocytes, and histamine production. And as you may know, histamine and other mediators can induce oxidative and dissociative stress, blood-brain barrier opening, transmigration of circulatory inflammation cells into the brain, and, some abnormalities in the limbic system of the thalamus. So I would like to stress only that, we are dealing with international phenomenon, which is not restricted to any country. It's worldwide a plague, a type of plague, because if we interpret the estimations that has been published in the literature, EHS persons are millions of patients worldwide, not only 100 patients, millions of patients worldwide. Many of them are not, known because they don't know what they have, but with this diagnosis criteria, we could have, an evaluation of this phenomenon. So we had congress in 2015 in Brussels on electromagnetic field, and make at this step, you can recognize here Ol Johnson, Leonard Tardell, William Rea. I would like also to stress that William Rea had a very good, work on this field, David Carpenter, and other people. I would like to during this workshop, we stress WHO to code, to have a coding system to define EHS and to make EHS entering in the International Classification of Disease. And Magda Havas said to me in Canada, in Toronto, said to me several days ago that now WHO is considering the possibility that non-ionizing electromagnetic radiation has special health effect of this non-ionizing radiation can enter the new International Classification of Disease. They still don't, to my knowledge, they still don't speak about EHS, but it is, on the way, and I think it is on the good way. So I would like to stress that now nothing will be done without the advice of WHO. It is not, we cannot, fight by, by ourselves. It's not enough. Politicians will change their mind only if WHO is, changing his mind. So it is the reason that we will organize, at the end of the next year, a consensus meeting on electrohypersensitivity, similarly to what has been done in 1919 for MCS. And we hope that we could convince WHO, maybe it's a dream, I am not naive to consider that it will be easy, that it will be not easy, but we have to fight against ICNIRPs. This is clear. So this is what we should do. So in conclusion, I would like to finish to sum up exactly what I have showed in this study. First, it will be short. First, to sum up, whatever the cause of electrohypersensitivity, it is a true organic pathological disorder, which should not be considered as a nocebo-associated functional impairment or as a psychiatric disease. Second, MCS is associated to EHS in 25% of the cases. That means that chemicals as a causing agent may also be involved, to explain the occurrence of EHS. Since in some cases MCS first, EHS second, but the contrary is possible. Contrary to what is claimed by WHO, was claimed by WHO in 2005, we have characteristic clinical picture to define this disease with non-subjective, objective symptoms in some way. We can base our diagnosis on markers and imaging techniques, which make the medical diagnosis possible based on objective information. The proposed mechanism of action is based on histamine. The main proposal is based on histamine and oxidative nitrosative stress. We are dealing with a plague worldwide. And this is, the force we should have to convince, WHO that they need to have some they have to take their ethical responsibility. WHO at the moment, does not consider Alzheimer's disease, does not consider, electrohypersensitivity at the right level. So WHO have to revise its 2005 statement, which revealed to be totally incorrect. Thank you.